Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
November is Lung Cancer Awareness Month. It's a time when we focus on the progress that we've made in our efforts to combat lung cancer, and a time when we try to make people aware of the importance of lung cancer screening and for that matter, lung cancer early detection. Advances in screening, and probably even more so in terms of treatment, have made a huge difference in lung cancer over the course of the last 10 to 20 years, and those changes keep occurring. Tonight, I'm very happy to have Dr. Sarah Goldberg, who is the director of the Division of Thoracic Oncology in the Yale Cancer Center. She's a professor of medicine and is a true lung cancer expert. Her research focus, which she'll tell you about later on, is largely on what are called EGFR positive cancers, and we'll explain what that is, and on the role of immunotherapy, which is very important in lung cancer. So we have a lot to talk about, and we'll get going. Sarah, welcome to Yale Cancer Answers. Thanks so much for being here.
Thank you so much for having me. It's wonderful to be here.
Yeah, so maybe we can just start with some basic numbers. How common is lung cancer?
So lung cancer is common. It's not as common as breast cancer in women and prostate cancer in men. Those are the most common cancers among men and women. But lung cancer is second most common. So it is very common. I think where lung cancer, unfortunately, comes in first is it's the most common cause of cancer deaths, both in this country and worldwide.
Yeah, I mean, that's a fairly dramatic statistic. And in the U.S., how many men and women lose their lives to lung cancer each year?
Well, it's pretty terrible. It's more than 125,000 people every year will die from lung cancer.
And what about the global problem?
So it is a huge global problem. More than 1.8 million people every year will die from lung cancer worldwide.
Yeah, and unfortunately, it's estimated that that number is only going to increase. And in spite of the fact that we're doing better in the U.S. as smoking rates go up around the world and smoking is still very common in many parts of the world, this is something we have to deal with. All right, so let's first talk about how lung cancer presents. So a new patient comes in and sees you. What are the different ways that people come to medical attention?
It really is variable. Some people will have symptoms based on the mass or the tumor in their lung. So they might have shortness of breath or cough, sometimes chest pain. But I think just as often, people just sometimes generally don't feel well. So they might be more tired than usual. They might not be as hungry. They might be losing weight. And so sometimes it's much more nonspecific. Sometimes also because lung cancer tends to spread to other parts of the body, unfortunately, far too often, people will sometimes present with symptoms of it in another part of their body. So they might have pain from cancer in a bone or in other parts of the body.
Or even a headache and a neurologic problem occasionally.
Exactly. We do sometimes see that where because the cancer spread to the brain, they'll have symptoms from that initially.
And for many years, lung cancer, I think people thought was something that if you got it, you would almost certainly die from it. That's changed. Still, for the majority of people who present with advanced lung cancer, where the cancer has spread outside of the lungs and certainly the regional lymph nodes, it's something that eventually threatens someone's life. But what about for patients with earlier stage lung cancer?
I tell this to my patients all the time. Lung cancer can be cured. So having a diagnosis of lung cancer is not a death sentence.
Really important.
It's really important. I think a lot of times people hear that they have lung cancer or their loved one has lung cancer and that's the end, but it's not. Just as you said, the stage of the cancer is really important when it's an earlier stage. So that's stage 1 or 2, or even locally advanced, which is stage 3. That's when typically it's either a larger tumor or in the lymph nodes. Lung cancer can still be cured. And the ways we can cure lung cancer are with surgery and with radiation. We sometimes add chemotherapy and immune therapy to that, but those modalities, often in combination, can cure lung cancer. But actually, the amazing thing now is that even for stage 4, we occasionally can cure lung cancer. Some of those patients are able to be disease-free for so many years that it's as if they're cured because they just go on and live well for so many years. And eventually they might die from some other illness and the lung cancer was never a problem.
And there are others who get what we refer to as targeted therapy, so therapy directed against a very specific molecular change in the cancer, who can maybe not be cured, but who do well with it for years and years in a way that was not possible 20 years ago.
That's exactly right. So targeted therapy has revolutionized how we think about and treat patients with lung cancer and how well they do. So targeted therapy refers to the idea of using a specific treatment or medication to target the problem, so to speak, in the cancer cells that's actually driving the cells to grow and divide and spread and be a cancer. And so if you could identify that problem or abnormality in the cancer cells, in the DNA of the cancer, and you could target it using a treatment, in many cases, we see incredible results in our patients when we can use those therapies in the right patient.
And do you think that compared to, even 10 years ago, and our audience can't see this, but Sarah is not someone who has been practicing oncology for 40 years. She's a little younger than that. And so I won't ask you about 25 years ago. I'll won't ask you more than about 15 years or so. But do you think that people coming in are a little more optimistic because of these changes than they used to be and less fatalistic about what lung cancer means?
Absolutely. These therapies and others, which I'm sure we'll talk about, have really changed how well people can do with lung cancer. So you mentioned I'm not able to comment on 25 years ago, but you're right. 15 years ago, when I was in my training and just starting out as a junior attending, we had some targeted therapies. That was really when the revolution was beginning, when we were first able to target certain abnormalities in lung cancer. So we had EGFR inhibitors then. We were just starting to get ALK inhibitors. Those are two abnormalities or mutations, alterations in the genes of the tumor, EGFR and ALK. And so we had those, but that was really it. And we really only had 1 or maybe 2 drugs for each of them. Since then, so even just in the last 15 years, there has been an explosion of both targets that we can identify in people who have lung cancer in their tumors and drugs to treat each of those targets. So now in some cases, we have 2, 3, 4, 5 drugs that work well for that target. And we have so many different alterations that we absolutely have to check for when we have a patient in front of us diagnosed with lung cancer, because it changes how we think about it. It changes how we treat the cancer. And just like you're saying, it changes how well people do and the outlook for them, the prognosis. With these targeted therapies, people can live for a very long time with really good quality of life in many cases. They tend to have less side effects overall than a lot of our other treatments. And so it's almost like a win-win. I tell my patients, they tend to work better and they tend to have less side effects than a lot of other cancer treatments.
And these targets are because of specific genetic abnormalities in the lung cancer. Is that correct?
Correct. Yes. In some lung cancers, probably around, it depends where you are in the country and in the world, but somewhere around 15, 20, 30% maybe, or more even in some parts of Asia, we will find an abnormality, a mutation in the genes or in the DNA of the lung cancer cells. So these are not abnormalities that you find in the patient's normal cells, you take a swab of their skin or of the blood, you wouldn't see these abnormalities or mutations in their normal cells. It's just in the cancer. And that's exactly what we're looking for, because we can take advantage of those abnormalities by targeting them with these treatments.
Well, I often say that all cancer is fundamentally a genetic disease, but that doesn't mean it's an inherited disease.
Exactly.
And it's because for a cancer to become a cancer, the genes in the cancer cells are fundamentally different. It's just that we can't always target them with drugs. And sometimes there are lots of genes that are just going crazy in the cancer cell. And sometimes it's really mostly one that's driving the behavior of that cell and the tumor. And that's what you all have found.
That's exactly right. And we actually call them driver oncogenes, meaning it's the abnormality in that gene, the oncogene, is what's driving the cancer to grow and divide. And that's what we need to stop.
Well, we've previously on this show had your colleague Lynn Tanui on to talk about lung cancer screening. So I don't want to spend a lot of time on lung cancer screening. But can you comment briefly about the potential importance of lung cancer screening and how little is done?
Yes, that is so important. And actually earlier when you asked me about how someone presents with lung cancer, occasionally we do see people who present because they had lung cancer screening. So sometimes people have no symptoms at all, but their doctor was a very good doctor and sent them for a lung cancer screening CAT scan. And sometimes we're able to find lung cancer that way. So the idea of this is it's very similar in idea to a mammogram or a colonoscopy. We're getting a PSA to look for prostate cancer. It's basically trying to find cancer before someone has symptoms to be able to detect it at an earlier stage where we can cure it and have a meaningful impact on that person's survival because of that. And so lung cancer screening has been proven to be effective. It's been proven to find cancer earlier. And because of that, it's been proven to reduce lung cancer deaths. And so it is a standard practice now that people who are at higher risk of lung cancer should get lung cancer screenings by getting a CAT scan once a year. The challenge is that doesn't always happen.
And can you just define high risk for a minute?
Yes. So high risk, the way it was studied and the way that it's been implemented is people between the ages of 50 and 80 who have smoked 20 pack years of cigarettes or more. So 20 pack years is, 1 pack a day for 20 years or 2 packs a day for 10 years, that type of thing. So there are probably other risk factors that maybe do make people higher risk, but for lung cancer screening, those are the ones that are used.
Yeah. So it's not a huge population that's eligible if you look at the total population, but it's a sizable number of people. And of that sizable number, my understanding is that there aren't too many people who get screening. And where would you put that figure in terms of the proportion of the eligible people who actually get screened?
Right. So first of all, it's just a comment on what you said of it's not a high percent of people that are eligible. There actually are a lot, and it varies, state to state, region by region.
Sure.
Some parts of the country, there's a lot more smokers still than others. The other thing, and I didn't mention this, it's not just people who are current smokers, it's even people who have quit. So there actually are quite a few people still that maybe they don't smoke now, maybe they haven't smoked in years, but because they have this history of smoking, they're still at higher risk.
Yeah.
That risk
I was just meaning it wasn't
not everyone.
It's not like mammography, which is applicable to all women above the age of 40 or 50.
Yes, exactly. So that's true. It's not just if you have lungs.
Yes.
It's if you have lungs and a higher risk, which I think is part of the reason why it's not implemented as much, because there's this extra piece where you have to figure out the risk. But it's probably somewhere around 10% of eligible people get screened. That varies state to state, region to region, but it's much less than it should be. We should be screening a whole lot more people who are at risk of lung cancer to find cancer early and cure them.
Yeah, and it is, of course, so different from mammography, where if you take all women over the age of 40, which is when it is recommended that we start, that well over half the population is getting regular mammography, and here it's a more select group, and it's only 10%. Well, we're going to have to take just a very brief break. We will be back in a minute, and we will continue our conversation with Dr. Sarah Goldberg, who is a lung cancer expert and director of the division, chief of the division of thoracic oncology at the Yale Cancer Center.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where patients diagnosed with pancreatic cancer are provided easy access to specialized care, including innovative treatments and clinical trials. Learn more at smilowcancerhospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to the second half of Yale Cancer Answers, focusing this evening on lung cancer while we're in the midst of Lung Cancer Awareness Month. That is November every year. I'm joined tonight by Dr. Sarah Goldberg, professor of medicine at Yale School of Medicine and a lung cancer expert. So, Sarah, let's talk a little bit about smoking and how important it is in terms of causing lung cancer. In the past, we thought of almost all lung cancer as being smoking related. How big a risk factor is smoking? And today, what proportion of cancers are smoking related?
Smoking is still the number one risk for lung cancer. It's the biggest one that we know about. And like we talked about before, still, even though it's much less than it used to be, there still are many people who smoke now or have smoked in the last few decades, and that puts them at risk for lung cancer. The important thing to know, though, is that there are people who get lung cancer who have never smoked and don't even really have secondhand smoke exposure. So there are other reasons why people get lung cancer, and we don't fully understand that. So it varies based on the population where you are in the world, but probably somewhere around 20% of people with lung cancer have never smoked or have a very light distance smoking history.
Sure. And those cancers tend to be a little different. They tend to have more of these driver mutations that you were talking about before, these genetic abnormalities that we can target. And the people who smoke tend to have a different sort of cancer where there aren't these driver mutations, but there are just lots of mutations in many, many different genes. Do I have this right?
You have it exactly right. Most or many people who have lung cancer who have never smoked will have one of these mutations that we can detect and use a targeted therapy. Or unfortunately, sometimes we detect a mutation, but we don't yet have a targeted therapy available. And that's a big area of research. But yes, people who've never smoked or have a light smoking history in the distant past, they tend to be the people where their cancer have these driver mutations that we can sometimes target with treatments. And on the other hand, people who have smoked, their cancers have a lot more mutations. We used to think of that as a big problem because they weren't eligible for targeted therapies, but there's a interesting silver lining there, which is the more abnormal the cancer is, the more mutations it has, the better a different type of treatment tends to work, which is immune therapy. So It used to be a really big challenge when we couldn't find a target for these targeted therapies. But now we have immune therapy over the last several years, and that has really changed the way we could think about treatment for those patients.
So let's go down these two different paths for a minute. So for the patients who typically aren't smokers, haven't been smokers or heavy smokers, and they have these driver mutations, we now have multiple different drugs. And about how many drugs do we have that can be used in this situation? And I realize that any given patient can't receive all of them because some of them are for a mutation that someone might not have. But it used to be there were a couple of these. Now it seems like there are at least half a dozen or more.
Oh, there's well more than that. So there's probably around 9 or 10 genes that we really have to test because we're able to target them in lung cancer. And, we haven't really talked about the different types of lung cancer. There's actually several different subtypes. The main subtype of lung cancer where we find these mutations is the type called adenocarcinoma. And that's the most common subtype.
And it's a more typically non-smoking associated lung cancer.
It's variable. People who haven't smoked do tend to get adenocarcinoma, but even smokers sometimes will get adenocarcinoma. So the adenocarcinoma group is really a mix in terms of smoking history. But it's really the adenocarcinomas that tend to have these mutations. And so I'm mostly talking about people who have more advanced disease. That's mostly where the targeted therapies are used, although we have started to now use them in people with earlier stage disease to try to improve our chance of cure. But we are required to test for all of these genes in people, particularly with adenocarcinoma, but even sometimes in other subtypes, because we need to know this information. So we test our 9 or 10 genes. Actually, at Yale and many other places, we test like hundreds of genes. We actually know a whole lot about the cancer, but these few genes are really required. But for each one, there may be several drugs available. And it does feel like every couple of months we get a new FDA approval for a new targeted therapy. So you have to really keep up with the approvals and the availability of these drugs, because a mutation that we sometimes, that we may not have been able to target a few months ago, we now might have a new treatment for. So you really have to stay on these things.
And some of these drugs, so 9 mutations, sometimes multiple drugs for each of these. Some of those multiple drugs, so let's say for EGFR mutations, some of them, am I right, are a little bit Me Too-ish kind of drugs, and some of them are drugs that work when the first drug no longer works.
So EGFR is a great example to talk about, partly because it's one of the most common driver mutations that we find in lung cancer, and also because we do have a lot of drugs. And it was one of the first ones discovered. So we've had now 20 years of developing drugs for EGFR. And I'm also very involved in this sort of research. So it's a good example to talk about. So yes, some of the drugs, especially the older ones, worked very well, but not for very long. And so we had a couple like that we used to use. This is really when I was in training, when I first started practicing, and they were amazing. They shrunk the cancer. They worked really well, but it wore off quickly. And so we could sometimes sequence them where we used one. When it stopped working, we used another one. But what we learned over the last 15, 20 years is if you have a drug that seems to be better than the other ones, it's actually typically best to use that one first. So that's really what we've done now. We've taken what
they keep moving up in the line.
They keep moving up. So it may be that we used to sequence, but when we see that this drug that we're using second or third is really so effective and in a lot of cases has less side effects, we're now moving that up to the first treatment.
And is there any value using one of those earlier, first generation drugs after you've used a third generation drug? Do you ever see anything? Typically
not. There's all sorts of research still going on. We do a lot of the trials here for EGFR and a lot of these other mutations where we're trying to figure these things out. How do you best sequence? A big question now, especially with EGFR, is should we be combining these drugs? Because for years, we used them on their own and they worked great. But none of these drugs, as great as they are, none of them are curing people. Sometimes they're working for years and years. I've seen people where it works 10 years or more, but they're not a cure. And so we're still trying to do better. And one of the ways is to try to combine them. So we're now starting to use our best drug first and thinking about combining it with other drugs and really trying to make those treatments even more effective and work for longer.
Yeah, no, it's really quite remarkable. So now let's switch to the other big group, which are the patients who don't have these targetable mutations, but have cancers that have many, many genetic alterations. And there you have immunotherapy. And is immunotherapy given by itself, or is it given with chemotherapy? How do you do it?
We have refined this over the years also by doing many different clinical trials trying to answer that question because it wasn't so obvious. And we've also, initially when it was being developed, we used it after other treatments failed and when they stopped working. But now we really have moved immune therapy to the initial treatment people get for advanced disease. We also often now will use immune therapy for people who are eligible for surgery, who have early stage disease. We sometimes use it before or after surgery, after radiation, we use it. So we're using immune therapy across the board in a lot of different scenarios. But to answer your question about how we use it, it depends. We sometimes do. We sometimes use it on its own as a single drug. So one immune therapy drug, they're called PD-1 or PD-L1 inhibitors. And there's a few different specific drugs, but that's the class. We can sometimes use it on its own, and it sometimes works incredibly well. We look at particular markers on the cancer cell. There's something called PD-L1 expression to help us figure that out. So with high expression, we think those tumors are the ones that are really going to respond to even just a single drug.
Yeah.
Yes. So we can do it by itself. And that's amazing when we can do it by itself. We could skip chemo altogether because that's really the other thing we combine it with is chemotherapy. So with the high PD-L1 expression tumors, we think on its own immune therapy may have a good chance of working and sometimes for a very long time. And we can give people a chemo-free regimen for their advanced lung cancer. And that's just amazing. In a lot of other cases, we are combining it with chemotherapy, and we think that helps it work better.
Well, your comment about clinical trials made me remember to say that none of these advances would happen without two big things. One is truly dozens and dozens and dozens of clinical trials with thousands of patient participants who volunteer to be in these trials, hopefully to get a better treatment themselves, but also to help us make progress for patients in the future. But then the other piece is funding for research. Looking into the future, it's going to be a long time before we eliminate all deaths from lung cancer around the world. But let's just think about the United States for a minute. And could you imagine a time in 20 years when lung cancer death will be a thing of the past? Not necessarily lung cancer, but losing one's life from lung cancer.
We have done so well in the last 20 years. If that pace continues for the next 20, we're going to be doing great. I think if we improve screening and we find these cancers earlier, we have a better chance of eliminating them. And then I think with the progress, as you mentioned, with understanding the biology of lung cancer and then bringing that into clinical trials to get better drugs, I think we're well on our way. It's a huge challenge still, right? It's the number one cause of cancer death. So we have a long way to go, but we are making amazing, amazing progress. It's a really exciting time to study lung cancer and take care of people with lung cancer when we have so many great benefits to offer.
Dr. Sarah Goldberg is a professor of medicine at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.